diverticulum is a congenital diverticulum involving terminal ileum and unobliterated proximal vitano-intestinal duct. The vitano-intestinal duct is a duct which connects yolk sac to the developing midgut. So if the proximal part of it, along with the terminal part of ileum, forms the Meckel's diverticulum. The proximal unobliterated part of vitalo-intestinal duct, along with terminal ileum, forms Meckel's diverticulum. Associated with Meckel's diverticulum, we can have esophageal atresia, anorectal malformation, and examphallos. Then some of the salient features of this disease is Meckel's diverticulum. We have the two facts. That's number two facts. That is, it is 2% common in general population. It is 2 feet away from the Meckel's diverticulum is 2 feet away from ileocecal valve. Only 2% of patients with Meckel's diverticulum is symptomatic, and female is to male ratio is 2:1. Then coming to location of this Meckel's diverticulum, it arises from anti-mesenteric border of ileum, and it has independent blood supply. As I already told, it is located 2 feet from ileocecal valve. Around 20% of Meckel's diverticulum mucosa contains heterotropic epithelium, meaning it's not lined by intestinal epithelium, that is columnar cells. More than 50% of time, heterotropic epithelium is gastric mucosa, which is most common heterotropic epithelium, followed by colonic and pancreatic tissue in 5% of patients. The clinical manifestation with which the patients with Meckel's diverticulum present are, majority of them are asymptomatic. 98% of them are asymptomatic. The remaining 2% of patients present with symptoms like, in less than or equal to 2 years of age, the patients can present with maroon colored blood in stools. This is due to the bleeding. You'll see how the bleeding occurs. The heterotropic gastric tissue can form peptic ulcer. Eventually, this peptic ulcer can erode the vessels, causing bleeding and cause maroon colored blood in stools. The patients having peptic ulceration of the heterotropic epithelium of Meckel's diverticulum can have features similar to that of acute appendicitis, that is fever, and then with abdominal pain in the right iliac fossa and other features like vomiting and all. They can have the features similar to that of acute appendicitis. Then some patients can have intestinal obstruction due to adhesions and due to intussusception secondary to Meckel's diverticulum. The Meckel's diverticulum can perforate and cause peritonitis. And rarely it forms gastrointestinal stromal tumor or carcinoid tumors. The Meckel's diverticulum. The gastrointestinal stromal tumor and carcinoid tumor can present with intestinal obstruction, or the carcinoid tumor can present with diarrhea, flushing, and other features. Also, in some patients, Meckel's diverticulum can be the content of inguinal or femoral hernia, which is called as Litter's hernia. Coming to management of this condition, investigations, we have technetium-99 radioisotope scan, which is done in case of bleeding if the patient presents with maroon colored blood in stools. We can do technetium-99 radioisotope scan. Around 90% of heterotropic gastric mucosa can be picked up here. Even minimal bleed like 0.1 ml per minute can be picked up by technetium-99 scan. We can do X-ray where we can see features of perforation and obstruction if it's present. Small bowel enema with fluoroscopy can show Meckel's diverticulum. The management of this condition, treatment, asymptomatic Meckel's diverticulum found in while performing other procedures like lap appendicectomy or lap cholecystectomy. If you find Meckel's diverticulum, we need not remove it. If the Meckel's diverticulum base is narrow or it is lengthy diverticulum, we should remove the Meckel's diverticulum. The patient are asymptomatic, we can perform resection of segment of ileum where Meckel's diverticulum is present, followed by end-to-end anastomosis of the ileum. Then, alternative to resection of segment of ileum, we can do Meckelian diverticulectomy followed by closure of enterotomy. But this procedure is associated with more rate of stenosis and retained heterotropic tissue. So we prefer resection of segment of ileum followed by end-to-end anastomosis. This about Meckel's diverticulum. To To summarize, Meckel's diverticulum is a congenital diverticulum of terminal ileum and an obliterated proximal vitalointestinal duct. It can be associated with esophageal atresia, anorectal malformation, and examples. The salient features are: it is seen in 2% of general population, 2 feet from ileocecal, where 2% are asymptomatic. Female to male ratio is 2:1. The location is arises from antimesenteric border of ileum as independent blood supply, and also it's located 2 feet from ileocecal valve. 20% have heterotrophic epithelium. Most common is gastric epithelium, gastric mucosa, followed by colonic and pancreatic tissue. Clinical manifestation: majority are asymptomatic. The patient can present with maroon colored blood in stools, and then the features of peptic ulceration similar to that of acute appendicitis. The intestinal obstruction, intussusception due to intussusception and adhesions, or features of perforation and leading to peritonitis can be present. Some patients present with letasthenia, where Meckel diverticulum is the content of inguinal or femoral hernia, or they can have features of cyst or carcinoid tumor, which has developed in Meckel's diverticulum. Investigation or technetium-99 radioisotope scan, where we can detect even small bleeding like 0.1 ml per minute. X-ray to see features of perforation obstruction if it's present. Small bowel edema and fluoroscopy labs to pick up Meckel's diverticulum. Treatment is asymptomatic. We need not treat this disease. If the base is narrow and we have lengthy diverticulum, we remove it. If the patient is symptomatic, we perform dissection of segment of ileum followed by anastomosis. Alternatively, we can do Meckelian diverticulectomy with closure of enterotomy. This is all about Meckel's diverticulum. Thank you for listening.